Y bien, hemos empezado este bloque hablando del futuro del IVF, la perspectiva del laboratorio. Hemos pasado por el consejo genético, inteligencia artificial y qué mejor para cerrar este bloque con uno de los hot topics que os hablaba de estos últimos años, que es la parte del mosaicismo, ¿verdad? Y para ello tenemos como invitada a la directora científica del Grupo Eugene, Dr. Mina Popovic. Please, whenever you want, the floor is yours.
Thank you very much for the introduction, and thank you very much, Nasser, for this invitation, and also to the whole iGenomics team for having me here. It's truly a pleasure, especially to talk about the topic of chromosomal mosaicism, which I've been working on for the last few years, and as we have heard, it's quite a hot topic. We've been debating it for several years. And what is quite striking still is that there is still no clinical consensus on whether we should diagnose mosaicism, how we should diagnose mosaicism, and what we should do with mosaic embryos. So today it's a pleasure to present some of the research that we have done within the Eugene Group on this topic. I'm not sure how to operate. Okay. So I don't have to explain to you that embryo aneuploidy is really a major factor that influences human reproductive success. And of course, we see an increase in the frequency of aneuploid embryos with advancing maternal age, and this is mirrored by a decrease in fertility. But what has been suggested is that ongoing pregnancy rates remain stable across all age groups if a euploid embryo is transferred. So the selection of euploid embryos should technically improve clinical outcomes, and this is really the premise for PGT A. And what we've also seen is that PGT A is really steadily increasing over the years, and these are just some results or statistics from the United States, and we can see that in 2018 up to about 40% of cycles, IVF cycles include PGT A, and the uptake does vary internationally, but we are also seeing here in Spain a big increase in the uptake over the past years. And we know that currently the state-of-the-art for PGT-A involves a trophectoderm biopsy of 5 to 10 cells and next-generation sequencing. But what complicates PGT-A is that the origin of abnormalities in human embryos is varied. So abnormalities can originate during meiosis, so during the formation of gametes, predominantly oocytes. And in such cases, not sure if the pointer is working, but in such cases, the abnormality, because it is present from the very beginning, it'll affect all of the cells within the embryo uniformly. And this is what we refer to as a uniform abnormality. So here we just have some examples of profiles following PGT-A. On the bottom, we have the different chromosome numbers, and here we have a relative copy number. So what we expect for a euploid embryo or for euploidy is that these values are around 0. So this would indicate that the embryo in at least this section of the genome is diploid. However, if we have a deviation from this baseline, then we can assume an abnormality. So in this case, we have a uniform abnormality, a trisomy 16, and it is reaching the threshold of what we would consider a uniform aberration. On the other hand, in the other graph, we have a monosomy, so a loss of a chromosome, and it is also reaching the threshold of what we would consider a uniform abnormality. So in such cases, these results are clear. Of course, these embryos are abnormal, and we would not recommend them for transfer. However, abnormalities can also originate during the mitotic divisions that underlie embryogenesis. And here only some of the cells will be affected because the abnormality will occur during development, so during the cell divisions. And this is what leads to these distinct chromosomal constitutions within different cells of the embryo, or what we refer to as chromosomal mosaicism. So in clinical practice, we are faced with profiles like this. So again, we see a deviation from this baseline, but it is not quite reaching the threshold of what we would consider a uniform abnormality. So as you can see here, the values that are around minus 0.5, which would suggest that around 50% of the cells within this biopsy contain an abnormality. So we diagnose mosaicism based on this intermediate copy number, and we can also use it to predict the number of abnormal cells within the biopsy. So we can classify mosaicism as low level if it's less than 50% abnormal cells, or as high level if we see more than 50% abnormal cells. And what led to a lot of controversy with these mosaic embryos is that originally we didn't really know what to do when faced with such profiles. And in the beginning, there was a lot of, the labs were more conservative and clinics were more conservative and actually didn't transfer these embryos. But there were then several studies that actually showed that blastocysts that are classified as mosaic do have the capacity to result in viable pregnancies. However, it was suggested that they may also entail higher rates of miscarriage. And more recently, non-selection studies have shown that actually blastocysts, yes, they do have the capacity to result in viable pregnancies. However, they do have equivalent outcomes to euploid embryos. So there is still quite a bit of controversy as to what are really the outcomes of these mosaic embryos. Nevertheless, because we have observed that they can lead to healthy live births, they have emerged as a third category of possible outcomes following PGT A. However, there are several factors to consider when diagnosing mosaicism, and that this diagnosis is hindered by several biological but also technical challenges, which I will mention in the next slides. And that there are still a lot of reservations regarding the clinical value of diagnosing mosaicism, and this is really complicating embryo transfer policies. And still, there are some concerns about the risks of transferring mosaic embryos. So all of these different concerns have led to different practices in the way in which we diagnose mosaicism. And in fact, there are different approaches. So as I mentioned, in the first approach, mosaic embryos are classified as a third category of embryos. And here, different thresholds are used to classify an embryo as mosaic. So either the embryo, the biopsy, has 20 to 80% abnormal cells, or 30 to 70% abnormal cells. So again, different classifications. Another option is that all mosaic diagnoses are just classified as clinically unsuitable. So in this case, embryos that have more than 30% abnormal cells are just not transferred. They are classified as clinically unsuitable, so not used. And another option that has been applied is that mosaicism is not reported. So any embryos that are diagnosed with less than 50% abnormal cells are classified as euploid, so clinically suitable. So as you can see, several different strategies that have perhaps led to a lot of confusion also within the field, and a lot of different thresholds being set. And another thing to keep in mind that I mentioned before are the technical challenges. So one thing that we are really faced with in PGT-A and what is really the bottleneck is the low DNA input that is being used. We're only analyzing about 5 to 10 cells from the embryo, so we really don't have much DNA as a starting point. So this DNA has to actually undergo a step of whole genome amplification. Of course, what we hope for is an even amplification across the entire genome. But what can happen is a biased amplification, so that certain portions of the genome get over or underrepresented. And this can lead to this technical noise. And these artifacts of amplification or even the sequencing may actually be indistinguishable from mosaic results. So we cannot always assume that this intermediate copy number really predicts a true mosaicism in blastocysts. And again, all of these differences in diagnosing mosaicism, the technical challenges in diagnosing mosaicism, may actually impact the number of euploid embryos that are available for transfer. And this was suggested in the STAR trial, which was performed by Santiago Munet and colleagues. And here we actually see a suggestion that laboratories and clinics that did not report mosaicism may actually have higher euploidy rates. So we have been on this mission to look at the impact of diagnosing mosaicism on PGT-A and really try to clarify some of the challenges that we are being faced with. So we approach this in two ways. So the first, we wanted to look at the accuracy of pre-implantation genetic testing for aneuploidies and really the accuracy of diagnosing mosaicism. And then also we wanted to look at the PGT-A results across different providers and clinics. clinics. Being a large group, we actually are working with several genetic laboratories, and we can look at the different results across these different providers. And we wanted to really look at how these different approaches affect the availability of embryos for transfer. So for our first approach, we actually used a bit more of a basic science approach in which we used the extended in vitro culture of human embryos. So this is a system that we have optimized in our lab, and it actually allows us to culture embryos beyond the implantation stages, so up to 12 days post-fertilization. So we actually plate the embryos in this system on day 6. They form an outgrowth around day 8, and this outgrowth then develops and expands. And we can see certain phenotypes within these outgrowths that are associated with post-implantation development, such as the formation of the epiblast, which you can see in the cells in green, and also the hypoblast, the cells in red. So these structures do mimic post-implantation development. And we use this system to culture several different types, let's say, or different embryos with different diagnoses following PGT. So firstly, we cultured, and in this system, we cultured a total of 230 blastocysts in total. So we had several uniformly aneuploid embryos, also some euploid embryos as controls, and then also a total of 57 mosaic blastocysts. And the mosaic category actually included both embryos that were diagnosed with an aneuploidy in addition to mosaicism, so they already had a uniform abnormality as well, but also perhaps the most interesting ones, embryos with only one mosaic abnormality. We call them mosaic only. And so we cultured these embryos for the 6 days, so up to 12 days post-fertilization. As I mentioned, they form outgrowths, and then we actually collected these outgrowths again at day 12 and performed sequencing. And we were able to look at the developmental outcomes of these different embryos with the different abnormalities, but also the chromosomal status of these embryos at day 12, and we could compare these to the trophectoderm biopsy. For a number of outgrowths, so for 24 embryos, we actually separated the outgrowths also into 2 to 4 portions. So for 66 outgrowths, we collected them in whole, and for 24, we actually separated them, and these pieces were then sequenced separately. So this allowed us to actually look if there was a mosaicism within these outgrowths as well. So first, when we look at the developmental outcomes, what we observed is that around half of these embryos remained attached throughout this extended culture up to day 12, whereas the other half degenerated and detached somewhere around day 8. And when we compare these developmental outcomes to the chromosomal profiles of the trophectoderm biopsy, what we observed is that euploid embryos and embryos with chromosomal gains, so trisomies and duplications, were significantly more likely to remain attached throughout this extended culture, whereas embryos that were diagnosed with monosomies, deletions, or multiple abnormalities were significantly more likely to detach. We also looked at the effect of uniform aneuploidies on developmental outcomes. So we stained a number of embryos to look at the different phenotypes and how these embryos actually developed throughout this extended culture. And what we consistently observed is that embryos that were euploid actually contained all the lineages that we associated with post-implantation development. So the ones that I mentioned, such as the epiblast, hypoblast, and in purple you can see the trophoblast cells. However, depending on the different abnormalities, we did see different phenotypes. So as you can see with the monosomies, they actually formed slightly smaller outgrowths, and again, and they didn't have, we didn't observe many lineage-specific cells. And the trisomies also resulted in different types of phenotypes. And when we count the number of cells, what we actually observed is that monosomies had significantly fewer epiblast-like cells compared to both euploid embryos and also trisomic embryos, and also less hypoblast-like cells compared to the euploid and trisomic embryos. So really what we can see is that these aneuploidies do affect development, and of course this coincides with data from clinical studies, like we observed before with the TEAG study, where actually abnormal embryos are less likely to implant and also of course progress throughout development. When we looked at the concordance rate also of these uniformly aneuploid embryos, so when we compared the trophectoderm biopsy to the results on day 12, what we observed is 100% concordance. So if we have a uniform abnormality, we assume that this is meiotic in origin, and we see it persisting throughout development. And of course, this is reassuring for PGT-A. We are good at diagnosing these meiotic abnormalities. We also observed 100% concordance when reporting euploidy. So if an embryo was called euploid, we could confirm this every time in the outgrowth. So this is just an example here where we can see the blastocyst biopsy profile and the outgrowth profile. What about the mosaic embryos? Perhaps the most interesting ones. Well, here we actually observed that 80.6% of them remained viable throughout the extended culture. And we actually see comparable results to the euploid embryos, apart from the aneuploid and mosaic embryos, of course, that had already a uniform abnormality. So these results were, of course, poorer. And if we look at the phenotypes of these embryos, we actually observed that they were very similar to the euploid embryos as well. So all of these embryos contained the 3 distinct lineages at day 12. And what we also observed is that 69% of the mosaic embryos were actually uniformly euploid at day 12 as well. So here are some examples of different mosaic diagnosis. In the top panel, you can see embryos that were diagnosed with low-level mosaicism, so less than 50% abnormal cells. So the first one, we have an embryo that was diagnosed with a mosaic monosomy 9. Sorry, that was can't see it precisely, but if you see in the outgrowth, we see no evidence of this abnormality. And in the second embryo, we see a mosaic monosomy 8 diagnosed at the blastocyst stage. Again, no evidence in the outgrowth. And in the bottom panel, we see embryos that were diagnosed with high-level mosaicism, so more than 50% abnormal cells. And in these cases, both of these embryos were euploid at day 12. And this is just a result also of an outgrowth that we separated into portions. So here we also had euploid results across the entire outgrowth, and this embryo was originally diagnosed with a mosaic monosomy 16 low level. So here we had 4 portions of the outgrowth, and as you can see, no evidence of this abnormality across the different samples. However, there was a number of embryos, so 27.6%, that were diagnosed as mosaic, but were in fact uniformly aneuploid at day 12. And what is very interesting is that all of these embryos were originally diagnosed as high-level mosaics. So this is an example here of an embryo originally diagnosed with a mosaic trisomy 21, high level. And when we look at the outgrowth, actually we had 4 portions of it, we can see a uniform abnormality, so a trisomy 21 across all of the outgrowth samples. And finally, we were actually only able to detect true mosaicism in 1 of the embryos, so 3% of the total embryos that we cultured. And in this case, we do truly see evidence of a mitotic error. So this is just a zoom in on chromosome 7. This embryo was diagnosed with a mosaic monosomy 7, as you can see in the top row. And in the outgrowth portions, here we had 3, we can actually see reciprocal events. So in the portion 1, we see a trisomy 7, and in portion 3, for instance, we see a mosaic monosomy 7, and in portion 2, it was a euploid profile. So this is true evidence of a mitotic error in which some parts of the embryo will have a gain of the chromosome and some a loss. So overall, the conclusions for this first part that we observed 100% concordance for whole chromosome uniform aneuploidies. So as I mentioned, this is reassuring for PGT A. We are good at diagnosing meiotic abnormalities. However, the positive predictive value is considerably reduced when diagnosing mosaicism, and the false positives are largely attributed to such diagnosis. So this raises a lot of concerns regarding really the accuracy, but also the relevance of these predictions. If we see that the majority of these embryos are in fact just euploids, should we really be diagnosing mosaicism, especially low-level mosaicism? So given these concerns, we also wanted to look at the availability of embryos for transfer across different providers. As you can see, there are some challenges in diagnosing mosaicism. So how does this really affect euploidy rates? So to do this, we performed a large retrospective study in which we analyzed over 36,000 embryos. This was an international study that included several centers and included results obtained from around 10,000 patients across close to 12,000 cycles. And a total of 17 IVF centers and 8 different PGT A laboratories across 5 countries participated in this study. And in fact, the study has just now been published yesterday in Human Reproduction. But I will go through it here. So as I mentioned, we looked at results from a total of 8 genetic laboratories. So these are the different providers, which we named A to H. And as you can see, some of the providers were serving only one clinic, whereas some providers actually provided their services to several clinics, like provider H, where we have a number of clinics, or provider C with 2 clinics. And we used a multi-level mixed linear regression to compare the associations between the PGT A providers and the different outcomes. We adjusted for several parameters, and our results included both autologous and oocyte donation, next-generation sequencing, PGT A cycles. We also evaluated a number of outcomes following mosaic embryo transfer. So these were performed across 15 of the clinics, and they included outcomes of the transfer of 245 mosaic blastocysts. So when we look at the different patient characteristics, as I mentioned, we had around 10,000 patients in the study. Mean maternal age was 36 years and mean paternal age 40 years. And what was interesting is that 10% of all the cycles were actually oocyte donation cycles. But as you can see, different clinics had different rates of oocyte donation cycles in which they performed PGT-A, which range from 0 up to 30%. And then when we look at the different providers and the way in which they firstly diagnose mosaicism, you can see here the differences in ploidy rates, and you can already start to see some differences. But what is also important to note is that in this case, provider A actually only diagnosed embryos as either aneuploid or euploid. So it used a binary classification and did not diagnose any or report any mosaic embryos. And we can see differences then from provider B and H. But overall, 49.4% of the embryos were aneuploid, or 44.9% euploid, and the overall rate of mosaicism was around 6%. So then when we looked at certain predictors of euploidy and mosaicism, so of course we confirmed that maternal age, with advancing maternal age, the odds of euploidy were lower. However, we didn't see this effect in regards to mosaicism, so maternal age didn't seem to affect these outcomes. We also observed that embryos that were biopsied on day 6 and day 7 had lower odds of being diagnosed as euploid. However, again, no effect in terms of mosaic diagnosis. And finally, paternal age, in terms of paternal age and the number of embryos that were biopsied had no effect on diagnosis of euploidy or mosaicism, which has also been previously shown. As I mentioned, some of the providers serve several clinics, so we also wanted to look at the impact of the clinic on these diagnoses. And for provider F at first, we didn't observe any differences amongst the clinics in terms of euploidy or mosaicism rates. And for provider H, we did see some differences in terms of euploidy rates, but for mosaicism, we see no differences. So what this can suggest is that there are certain factors as well that we couldn't control for from the clinical side, or patient factors that could impact euploidy rates. But in terms of mosaicism, we didn't see any technical effects of the lab, at least in our study. And what we observed overall is that actually the provider was the strongest predictor of PGT-A results. And if we look at the differences here in the rates of mosaicism that are being diagnosed from it not being reported, they range from 3% in the lowest instance to 25%. So quite some variability there. And we observed that provider B had the lowest rates of mosaicism, and provider C also had significantly lower rates of mosaicism, whereas provider E had significantly higher rates of mosaicism amongst the providers. We also then looked at the chance of having at least one euploid embryo diagnosed. And what we observed is that providers that had higher odds of having at least one euploid embryo available for transfer actually had significantly lower odds of diagnosing mosaicism. And this was also the case for the provider that did not report mosaicism. So the chance of having at least one euploid blastocyst available for transfer increased significantly when mosaicism was not reported. So when we compared provider A that did not report mosaicism to all the other providers. And here we can just see a different representation of these, where again the providers that had the highest euploidy rates had the lowest rates of mosaicism. So this reporting of mosaicism does come at the expense of euploid diagnosis. We also then looked at the rates of different types of abnormalities. So here we have the single uniform aneuploidies across the different providers. So these are the trisomies, monosomies, and also segmental abnormalities, so those that affect parts of the chromosome. And as you can see across the providers here, the diagnoses are quite consistent. This we can assume reflects true biology. On the other hand, with the single mosaic aberrations, we do see quite some variability, as you can see, across the providers. And some providers actually, for instance, didn't diagnose segmental mosaic abnormalities, whereas others did. And this can also, of course, affect the rates of mosaicism. And when we look at the different diagnoses per chromosome in terms of the uniform abnormalities, we consistently observed across the different providers that abnormalities that were associated with chromosomes 15, 16, 21, and 22 were the most common, and this has been also reported previously. When we look at the single mosaic aberrations, we observed that they generally affected all chromosomes uniformly, apart from mosaic trisomies 19. Here we really see a significantly higher number of such diagnoses, and this was a very interesting result to us because we know that chromosome 19 is actually very challenging to sequence. So this could really be indicative of a technical bias rather than true biology. And finally, as I mentioned, we looked at clinical outcomes following the transfer of mosaic embryos, so 245 mosaic blastocysts. And what I should point out here is that these were all low-level mosaics because these were the ones that were prioritized for transfer. But what was striking to us is that if you look at the overall transfer rate of mosaic embryos, it was only 12.7%. And as you can see across some providers and some clinics, in fact, mosaic embryos are just not transferred. So this ranged from 0% up to about 36.5%. But nevertheless, we can see that overall with this diagnosis, not many embryos end up being used for IVF treatment. And in terms of the outcomes, we can see an overall live birth rate of 35.2%. So we again confirmed the developmental potential of these embryos, and the clinical miscarriage rate was overall 5%. And when we compare these results to the transfer of euploid embryos, so these were the euploid results across the different centers and providers, we actually see equivalent results. So again, close to 35% live birth rate and around 5% clinical miscarriage rate. So we actually performed also a non-inferiority analysis looking at these outcomes, and we can see no differences in terms of similar outcomes for euploid and mosaic embryos. And we performed these analysis across all the clinics and also for clinics F because these were the ones that transferred the most mosaic embryos. But in both cases, we actually just observed similar outcomes following mosaic embryo transfer. So overall, we reveal a strong association between the genetic testing provider and PGT-A results, which was quite striking to us. And we also show that classifying embryos as mosaic may come at the expense of euploid diagnosis. And despite their normal developmental potential, close to 90% of mosaic blastocysts actually do not get transferred. So it seems that there is still a very high risk perception surrounding mosaicism. And these differences in mosaic diagnosis across PGT-A providers to us point to a technical bias as opposed to true biological variability. So we really have to be careful when diagnosing mosaicism. And this can especially affect patients with few embryos, and it can really mean a difference between success or failure in some cases. So finally, I would like to just mention some clinical implications. So really there is a strong need for standardization and quality assurance in the industry. And these false positive diagnoses may actually play a role in the failure to demonstrate improved outcomes with PGT-A. There is a lot of variability also in the literature, so perhaps we haven't seen an improvement with PGT-A due to this variability and due to this high number of false positive diagnoses. So current practices seem to limit the clinical utility of PGT-A per cycle by excluding potentially viable embryos. So until we can really be sure that the diagnosis of mosaicism accurately reflects this biological variability, reporting mosaicism really remains difficult to justify, especially in the cases of low-level mosaicism. And as I mentioned, it can really determine the difference between success or failure for some patients. So finally, I would just like to thank all our collaborators on this project. We had several centers across the Eugene group that participated in this study, as well as other clinics, external collaborators throughout Spain, also in Belgium. And thank you very much for your attention, and happy to take any questions.
Thank you very much, Nina, for your nice presentation. So, questions?
Thank you for your nice presentation. I have several questions. The first, in the study, you was speaking about the monosomy and the trisomy in the mosaicisms. And do you have this data with the segmental mosaicisms? Because I think it's very interesting also, because when you are checking the guideline, is the first option for transfer after you have euploid, and then you have mosaicism, the segmental is the first. Then I don't know if you have this study with segmental.
Yeah, we had a few mosaic segmental abnormalities. I didn't show them because it was few numbers, but in any case, they were all euploid always. What was interesting is that we also had some uniform segmental abnormalities that we cultured, so some embryos with these types of aberrations, and some of them were also euploid. So I think with the diagnosis of segmental abnormalities, it's still quite a challenge.
Okay. And the providers, you saw us, the different, when you are going to transfer the mosaicisms, the pregnancy rate is totally different. Do you have any association also between the level of the mosaicisms and the quality of the embryo?
Yeah, so we weren't able to unfortunately include the embryo quality. It's an important variable, but yeah, with the number of results we had, it was a difficult variable to receive from everyone. So we didn't have that, but in terms of, we know that most of these are all PGT, of course, embryos, so they're relatively good quality. They were all selected for biopsy. And overall, the classification of embryos, so the cutoff for an embryo biopsy was equivalent across the different centers. So. But the differences in rates also can be explained. I mean, in some centers, the number of transfers was so small, so it's difficult really to be able to compare amongst the providers.
Okay, thank you.
Timo?
Very nice presentation, congratulations, a very nice study.
Thank you.
It's amazing. And according with the present data about the mosaicisms, do you consider that it's ethically not to report the mosaics to the patient? The decision to report or not to report the mosaic embryos is for the lab or the company that make the diagnosis for the doctor. The doctor can ask to have the diagnosis of the mosaicism or not to have the diagnosis.
Yeah, so that's a very good and interesting question. I think that there are certain genetic tests which we are performing, even for instance prenatal testing and so on, in which we find diagnosis of uncertain clinical significance. And many times the laboratories don't report them at all. And I think to me it's quite strange that when faced with this diagnosis of mosaicism, there has been so much controversy only because we didn't know what to do with these kinds of diagnoses, and the genetic laboratories were reporting them. But in fact, now the more we learn about it, it seems that these could be actually considered of uncertain clinical significance. And especially what we see with the low-level mosaics is that they all result in euploid outgrowths, in euploid embryos. So I think, and even in healthy live births. So, and we don't see really differences with euploid transfers. So I think in this sense, there is enough evidence to consider these as, uncertain clinical significance, or at least, and then not report them from the laboratory. I think the confusion comes is when they are reported, and when the clinician is faced with this result, and when they have to discuss this result with the patient. And as soon as you start talking about embryos that have some abnormal cells and so on, it becomes very difficult. And perhaps what the approach could be is to try to refine the algorithms behind these predictions, so that in fact even the genetic laboratory doesn't need to be faced with this diagnosis, rather than finding a way to actually not report it and to adjust these thresholds. I think perhaps we were being overly sensitive with the thresholds in the beginning.
More questions?
Mina, congratulations. It was a very fantastic talk and also excellent work.
Thank you.
I was wondering if you have any idea, in the study you presented, culturing the embryos until day 12, I think, these that were diagnosed as mosaic that end up being diagnosed as euploid. What's your idea? How can this happen? Do you have any idea of the mechanism, or is it just because the euploid cells replicate faster and then take over? What's your idea?
So this is an interesting question. I think the first part is that we have to admit that in some cases we are overdiagnosing mosaicism. So I think that a part of these results are actually just technical artifacts, and we are not seeing them later on. But another aspect of that could be that, the euploid cells the aneuploid cells divide slower, as we saw in the presentation previously, that aneuploid embryos have abnormal metabolism, they are progressing slower, they're not proliferating. So basically the euploid cells outgrow, they proliferate faster, and they will outgrow within the embryo. So I think that this is one mechanism. There are several other mechanisms that have been proposed, but I think they are a bit more far-fetched. I think that this seems the most straightforward, and we know in nature normally we take the most straightforward path. So I think this makes sense. But yeah, there could be other technical factors such as contamination or something as well in the original sample that could have also lead to these discrepancies. But in terms of a biological mechanism, I think this competition and the euploid cells prevailing is the most likely scenario.
Hi, Mina, many thanks for your presentation, very nice. My question is related to the chromosomes, specific chromosomes, because BOT has trisomy 21 confirmed in the pregnancy. I have seen that you have observed also a trisomy 21, just confirming in day 12 development. Do you think that some chromosomes are more risky to follow in the development and to be in the pregnancy?
Yeah, one thing to note here is that, it was a trisomy 21 that we showed as an example, but we see that many of the actually high-level mosaics are confirmed. So I think this is the more relevant aspect to the conclusion. In terms of the different chromosomes, of course, we try to look at it. We have a limited number of embryos as well, so it's difficult to really, per chromosome, look at certain developmental potential. I think that, there is the assumption, and as we know from the guidelines from different societies, that certain chromosomes, of course, that may be associated with viability should be prioritized less. But overall, what we see with the low-level mosaics is that regardless of the chromosome, they will end up euploid. And for the high-level mosaics, here it is a bit more difficult because we see that some of these are in fact just euploid, but some of them are actually a uniform abnormality. So in this case, this can be a lot trickier, and this is at least with the platform that we looked at here. I think there is also could be some variation amongst the different platforms as we see from our other studies. So I think it's difficult to really be able to say what chromosome specifically should be avoided, but on the other hand, I do understand that, from a genetics point of view and genetic counseling, that certain chromosomes may be associated with greater risk, so we should be careful if we have a mosaic diagnosis. So, but even for instance with embryos, originally it was suggested that embryos with mosaic monosomies should be prioritized, but as you know, in true mosaicism you have both trisomic and monosomic cells, so again, even this prioritization is not fully justified. So I think it's really difficult, and I think we should focus more on, as I said, standardization and really assuring that we are seeing true biological variability before we go into a detailed debate on the different chromosomes and their potential.
Okay, so my take-home message would be like, we as a clinics must ask to our genetic providers about the thresholds of mosaicism. It's not the same 20 to 30%. We must ask also about the validation of the platforms and the algorithms to diagnose properly and accuracy the mosaicism, and also the average rate, because we observe the difference in between. I cannot imagine a 20% mosaicism rate in a lab. Yep. So if there's no more questions, thank you very much, Mina.
Thank you.